Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
Hello, I'm Mazen Nuruddin, Professor of Medicine at Houston Methodist Hospital and Director of Houston Research Institute in Houston, Texas. Welcome to this program titled Implementing the MASH Care Pathway in Practice. Today, I'm joined by two distinguished speakers, Dr. Fasiha Kanwal, who is the Professor of Medicine and Chief Section of Gastroenterology and Hepatology at Baylor College of Medicine in Houston, Texas, and Professor Ray Kim, who is a Professor of Medicine at Mayo Clinic College of Medicine and Science in Phoenix. Welcome both.
Thank you.
Thank you. We're talking about now a very common problem, which is considered pandemic in this country and around the world. So MASH is a part of disease syndrome called MASLD, and MASLD is a very common disease affecting about 30 to 40% of the population. So it's extremely common. Luckily, not everyone progress, rather subpopulation, and those are the population that is called MASH, about 10 to 20% of the population as just mentioned. And MASH is the issue where patients on top of the steatosis get inflammation and cell injury and eventually get fibrosis. And fibrosis is what determines the journey, where you start getting fibrosis all the way to cirrhosis and eventually liver decompensation, liver cancers, and liver transplant. So it's critically important to accurately determine fibrosis in patients because they indicates who is candidate for treatment and can determine long-term prognosis. And that has been the focus of hepatologists in this area for many decades now. So saying that, let me start with Dr. Kanwal, who can tell us about the current guidance for screening and diagnosis these patients. So Dr. Kanwal, what does it look like out there to screen this population and find those with fibrosis?
Thank you. Thank you, Dr. Nuruddin. As you mentioned, this is a very, very common condition. And I think that really presents challenges because how do you find these people among the many that are out there? And when I talk about these patients, we're talking about really people who have the risk factors, but also who have progressed to significant damage in the liver, many who already have fibrosis of the liver. So the first step that is very common across all of these guidelines or pathways is to find these people and to focus with certain key risk groups. People with diabetes and prediabetes is the number one risk group. People who have obesity with another cardiovascular risk factor, and those who might have steatosis, incidental finding on liver imaging. Let me ask Ray, do you agree with these three broad groups, and if there's anything else that you want to add to that?
Sure. I mean, the list is comprehensive, but the point I would emphasize is that you indicated that diabetes is the major risk factor for this condition. It is also a major risk factor for fast progression. So it is important for us to holistically evaluate the patient.
Yeah, that's a very important point that you mentioned. And I think the point here is that these are the big risk groups per se. But there are nuances that I think one has to be aware of. There are other similarities across these pathways is sort of using a two-tiered approach to screening just because it's a large population that one has to go through. And most of them, they start with using non-invasive testing, something that is easily available, cheap to do, and could really be done based upon routinely collected clinical information. And one test is FIB4, based upon lab test and age. That is the first tier test.
for the GI hepatology people who are in the audience, the first part of this pathway is directed for primary care physicians who hopefully will be energized to discover these patients and refer them in for second tier assessment. For a GI or hepatologist specialist, I think we have to have a game plan. If you're ordering fifth floor as a GI, I think that's not an ideal situation. You want to have your own sort of a algorithm. I have access to transient elastography, so I will go to that, or I have access to MRE, go to that, have a sort of a ultimate diagnosis planned, rather than starting over with fifth floor. It's not for us. It is for the primary care docs to really do the initial steps. So we'll talk more about the specialized NITs
Yeah.
soon.
Yeah, Dr. Canwell, you mentioned earlier that there are multiple guidelines or guidance there from multiple societies. Here we list some of them: the American Association of Clinical Endocrinology, American Diabetes Association, the EASL, which is the European Authority for Liver, had combined guidance with their Diabetes Society and Obesity Society, and finally we have the American Association of Study of Liver Disease. So, um, do you mind pointing out some agreements? So if you give me your opinions about across these guidelines.
Absolutely. I think all these guidelines, they emphasize the role of multidisciplinary management in patients because most of them also have other comorbidity and many also type 2 diabetes. So all the uh, professional societies and the guidelines, they do emphasize comorbidity management and shared recommendation. First, of course, assessing existing comorbidities, type 2 diabetes, hyperlipidemia, hyperpressure, chronic kidney disease, and really also emphasizing the importance of assessing cardiovascular risk in patients with MASLD. The other common theme is focus on type 2 diabetes management and assessment of insulin resistance. There are some differences across the guidelines, but most of them are very similar. For example, pioglitazone, which is a treatment that has evidence for benefit in patients with MASH, is recommended across all the different recommendation and guidelines. SGLT2 inhibitors are more heavily emphasized in the ACE and ADA, the diabetes guidelines, compared to more liver focused guidelines. But one common theme that you will see across all these guidance documents is the use of GLP-1 receptor agonists. Ray, you can talk a bit about resmetirom.
The difference between the guidelines is related to the timing of the release of the guideline. So obviously, guidelines that were made before the product became available, they don't mention it. And I'm not sure at this point if it is approved in Europe as of today. So their emphasis will be different. But in terms of multidisciplinary care, I want to just say something that may be practical. So most people in GI, I don't think they're equipped to deal with their comorbidity management. People are more attuned to GI issues. So if you ask practicing GI doctors to manage their diabetes and hyperlipidemia, I don't think that's a doable plan. Those issues that need to be managed, which is super important again for the holistic care of the patient, make sure that somebody takes care of that, whether that is a referring physician or another endocrinologist that is in the network, or an APP or some other staff in your own practice that can deal with it. Um, it just needs to be clarified who's doing what.
And Dr. Canwell, let me go back to you. We have a lot of tools out there. On the other way around, it can get confusing. And my comment to that, actually, I say to people, create the test that you comfortable with, in accordance with the guidelines, and stick to it. Can you just walk us through these tests, show the audience how many options we have?
Yes, I think the point that you made was a good one. That it's a good thing. It's a good thing that there's so many options. It's much better than not having options, but it does add complexity because which ones to pick and choose from. There are many that are already here, tests, and I think more are in the pipeline. And you can sort of think about them in different buckets. One is more blood-based tests, serological test, and one is more imaging. And the third, I think, bucket is where you can combine these two. We are seeing an increasing number of tests that combine both blood biomarkers plus imaging, more of a composite score. So many options to pick and choose from. I'll mention a few names that are also on the slide, but I think sort of highlight the ones that are more commonly used. But for serological testing, non-invasive testing, outscore, I think, is the one that is more commonly used. It's a composite score based on three different markers, and good data in terms of uh, separating patients with fibrosis versus less important fibrosis. Still, I think the issue with ELF is that the cutoffs are still emerging. There are more data that we are waiting for, so that sort of is one factor that we need to be aware of. Some other tests that are listed here, FibroSure, LiverFast, um, performance probably is similar to simpler tests in treating FIB4. But again, it's good to have these options available. Imaging-based tests are playing a more important role, at least in GI hepatology clinics, but even in primary care clinics. Here, the vibration control transient elastography, or VCTE, that looks at liver stiffness measurement is probably the most leading imaging-based non-invasive test. Quite a few practices have access to it. It's easy to order. And also there is a lot of information that has come out and is being generated in terms of its performance, and also as a great prognostic marker for long-term outcomes. So I think we're getting comfortable with use of VCTE, especially with the amount of information that is available for this test. Two of the tests that are important to mention are a shear wave elastography, similar performance as VCTE, and MR elastography, which when you compare them head to head, has a better performance. But the issue with most of these tests in the end is access and cost. And what are the tests that are available for use? I will not spend a lot of time on the tests that are more combination tests, but again, just one point, there are several that are available. We need more data, I think, for us to start using them in clinical practice. The more common tests that I see being used are VCTE, MRE, and ELF. But I'm going to have turn the conversation to Ray, and maybe you can walk us through the AASLD guidance.
So in terms of imaging guidelines, AASLD has multiple non-invasive test guidelines, and the most sort of accurate thing to do is imaging-based guideline, imaging-based non-invasive test. And my rule of thumb is if you use histology as a gold standard, which is an imperfect gold standard, obviously, MRE gets at about 95%, 90 to 95% accuracy, and transient elastography maybe 80 to 85%. So it is not perfect, and there's a gradation. With regard to steatosis determination, that's easier. Histological criteria for steatosis is 5%. So if you see 5-6% on MRE, that is consistent with the steatosis. For the CAT score from transient elastography, the going rate is about 275, and that's a beginning of steatosis. If you have more than 330, that's pretty bad steatosis. But that's the easier part. It's the fibrosis that we use these imaging techniques for. And so if the rule of 5, if you have under 5, it's normal. If you're 10, you're beginning of the slippery slope of fibrosis. If you are 15, there's a concern for advanced fibrosis, liver cirrhosis. If you're 20, you have cirrhosis. You have 25, you have portal hypertension. So that's sort of the rule of thumb. Our guideline has a complex regime. I tend to really zero in on the transient elastography liver stiffness. So something between 8 and 12 is F2 and 3. If you're over 15, it's more likely to be F4. So that's the rough guideline. For MRI, I think of low threes like 3.1. That's the beginning of F2. If you're high 4, like 4.5, 4.7, then you're probably F4. So as you define your favorite liver assessment tools, those numbers are worth carrying around.
I like the fact that you were able to simplify by the rule of five. I think it's important to remember because there are lots of cutoffs that we talk about, and it's hard to really keep them in mind. I like the 1.3 and 3.1. So FIB4 1.3 and MRE 3.1. You flip it and you get to the low cutoff for both.
What do you guys think about sequential testing, and what's the literature behind that? I mean, we said FIB4 followed by transient elastography in primary care, but in your practice, Dr. Kim, you mentioned like the 95 and 85. What do you do? Like do you do sequential testing, or should people do sequential testing? How's that helpful?
Again, as for GI practice, I don't think you need to start with FIB4. Imaging-based and NIT is much more accurate. So we should be talking about that. But a common mistake people make is ignoring the prior step. So if you have a FIB4 score or some other a blood-based score, and then you perform a transient elastography to get a number, then you don't throw out the first part. You take that into account in your estimation as well. So if you have somebody with FIB4 score of 2.7 and FibroScan result is 10, you would consider maybe the FibroScan is underestimating the fibrosis degree or something. Just have a again holistic assessment of the patient situation, and not think of things as a unique, discrete information.
Dr. Canwalk,
Yeah.
is there a role for liver biopsy still? What do you think?
Um, uh, yes, in very small subset of patients. Patients and the clinicians that don't want to use liver biopsies, we do not really rely on liver biopsies to the degree that we did before. And there are few instances where we still use liver biopsy or still request for a liver biopsy. One is when the results for the non-invasive testing, let us say, if there are more than one and they're discordant, especially if the clinical picture is telling one thing, but the results are saying something else. And if I'm worried about dual diagnosis, another condition, autoimmune hepatitis is probably the most important one. So there is a role for liver biopsy, albeit very small subgroup.
And I think we'll also now like put it in context of treatment, and we'll see what some experts papers and ASLD guidance came up with, to kind of like pin down this very specific population that needs treatment, the F2 and F3, as well as to distinguish those that they have cirrhosis and roll them out because it's a different treatment and that we don't have available yet. But let me walk our audience through the resmetirom data. And as you know, like resmetirom now is FDA approved as liver-directed therapy for significant advanced fibrosis. And when did that come from? That came from the phase 3 Maestro-NASH trial. And in this trial, what we did, we had people with 3 and more metabolic risk factors entering in the trial and having MRI fat fraction of 8% and higher. And as the FDA required, they had to have a liver biopsy of to show the NAS score of 4, which is a score composite of steatosis, inflammation, ballooning, as well as they had to have a fibrosis. Most of the patients in this trial had F2 and F3. There were no cirrhotics in this Maestro-NASH trial that was published in the New England Journal in 2024. There were 3 arms in this study: placebo, 80 milligram, and 100 milligram. And there were multiple test points, including screening, week 16, week 24, and week 52. And importantly, the trial is still ongoing to show that we prevent outcomes. So I want people to focus back again on this 52 weeks. So what the FDA requires nowadays is that you do a liver biopsy before and after, and you prove that you get histological improvement in one of these points. On the left, you see MASH resolution, which is very much decrease in this score that I mentioned to you from, let's say, it's a 6 you enter the study to almost 0 and 1 without worsening of fibrosis, or you have improvement of fibrosis by one stage. For instance, F3 goes to F2, or F2 go to F1, and it can go further as well. So in the regulator's eye, if you do hit one of those, you will get what's called subpart H approval. You go on the market and you continue the trial until you show prevention of decompensation and liver-related events. And in this slide, I show you on the left that this study did hit both endpoints. On the left, I show you the improvement, or what we call it MASH resolution, which is steatohepatitis. Again, this zero in large kind of big idea is like score of 6 go down to 0 and 1. And it was 30% of the population on the higher dose, 100 milligram, compared to only 10% of placebo, with a delta that is statistically significant. In the middle panel, we see the fibrosis improvement, which, as we said, is prognostic in this disease. And you see also statistical significant in fibrosis improvement that led to this drug approval on both endpoints. What we notice in this study also improvement in the LDL. That's not one of the primary endpoints, but show you that the comorbidity is also being addressed. Looking at liver enzymes, you see a nice and quick drop in ALT and AST, as well as other liver-related enzymes. The side effects were mild to moderate, mostly mild GI side effects, diarrhea that subside around 9 days in some patients' population. Now, after the drug approval, the FDA did not require liver biopsy to start this medicine. And basically, what we started the conversation is would start with patients that they come with fatty liver, make sure they don't have other underlying liver disease, especially alcohol-related liver disease, autoimmune hepatitis. Once you ruled out, you put them on 3 buckets. So the buckets is green, orange, or red, and the traffic light. And as it sounds, so the green, this is like you have uh, kind of like a quick idea that they needs to be treated. And let's talk about, for instance, the VCTE 10 to 15 here, the MRE and ELF listed. Um, the orange, the reason why we picked orange, we use a little bit higher VCTE cutoff, 15 to all the way to less than 2019.9. And here, many of these patients are F2, F3, but some could be cirrhotics. So here we call for caution and to look for other things. As physicians, you're going to look for nodular liver, collaterals, but one of also important things that you look at the platelet numbers, such as 140. And we use the 140 because it was exclusion criteria. You can use 150 if you want. So these 2 buckets are the treatable buckets. And importantly, this drug is not approved for cirrhosis yet or any other drugs. This is really important, actually. We're seeing patients being treated despite them being cirrhotic. So extremely important that you don't do it for VCTE more than 20, MRE more than 5, and ELF more than 11.3. So here we have to be extremely cautious. Now, looking at what do we do over time, some people repeat liver enzymes at month 3, and then another assessment at month 3 or at month 6 with liver enzymes VCTE, and finally, and here is listed at the ASLD guidance, what we see is reassessment at year 1. And the ASLD adds that the thyroid function need to be assessed over time and look for those with thyroid disease.
The color coding is a little bit relevant here, that green is for everybody. Blue is for people who in whom it is relevant. So the guidance is not recommending that we do thyroid function monitoring all throughout treatment. It is people who have underlying baseline thyroid problem is recommended.
Very helpful guidance out there that kind of determine who should start in treatment, monitoring therapy. But let's see also other options that have been tested in clinical trials. So, Dr. Kim, do you want to tell us about the Ascent trial and what was done in that trial?
I'm happy to. This is the second compound that is on the horizon. And really exciting data were published about 3 months ago in New England Journal of Medicine. And this is a Essence trial using semaglutide in MASH patients. This is similar to the resmetirom study design. This is a long-term study up to 5 years at week 240. They had two parts, and the paper that I mentioned is for part one, where they compared baseline versus week 72 histology, and both were placebo-controlled study. And one thing to note is the dose that was used for this trial of semaglutide is 2.4 milligrams per weekly, and this is rather high end of the spectrum. And they instituted a 6-week dose escalation, as you can see there, to ease patients into the regimen. The patients are usually sort of a MASH patients that you expect, as you can see in the histological criteria. Criteria histologically, stage 2 or 3, and again, cirrhosis was excluded in this particular study. And obviously, patients who are already taking GLP-1 could not be in this study, whereas they could be in the resmetirom study for obvious reasons. The bottom line is shown in the slide that primary endpoints were the same as the resmetirom study. It is resolution of MASH without worsening liver fibrosis, or improvement liver fibrosis by at least one stage without worsening steatohepatitis. And the study achieved both primary endpoints with a gap between the treatment and placebo in the order of about 29% for the resolution of MASH and about 15% for fibrosis improvement. I find it interesting to compare the placebo groups between this study and resmetirom study. That this study has a much higher placebo response rate than the resmetirom study, and it may be related to the patient population. It just emphasizes for us to take into account the whole data before jumping to the conclusion that, for example, 63% responded for MASH resolution. That needs to be understood in the right context. Next. Safety issues. There's no new safety signal other than the GLP-1 generic adverse effects that people are familiar. GLP-1 causes the GI tract to slow down. So you see GI toxicity there, and nausea, early satiety, and so forth. It also slows down biliary flow. So there is a gallstone signal there, but none of this is new, is pre-existing with all the GLP-1 information from before.
Those are phase 3 trials. And maybe we also can switch gear and Dr. Ken will walk us one of the important phase 2 trials about tirzepatide that was published in the New England Journal using tirzepatide in MASH with fibrosis patients. Dr. Canwell?
Yeah, sure. I'm happy to. So these are, as you mentioned, these are phase 2 data. And phase 2 data, they're looking at not just the efficacy, safety, but also finding the right dose. For this tirzepatide, the study was published about a year ago, also in New England Journal of Medicine. And same patient population that we heard about for resmetirom and semaglutide, which is patients with biopsy-confirmed MASH and stage 2 and 3 fibrosis. So again, no patients with cirrhosis was included in the study. And again, a randomized trial, randomizing patients to 3 different doses of tirzepatide, 5 milligrams, 10 milligrams, and 15 milligrams, and with the placebo arm. This was a 52-week study, and patients received tirzepatide once a week, subcutaneous dose. And the data are very encouraging, just as they are for the other 2 treatments that were just mentioned, from 45%, 56 to 62%, so really high numbers of patients who received these treatments, they achieved resolution of NASH or MASH with the different doses of tirzepatide compared to 10% of patients in the placebo arm. So again, the same endpoints that we heard about and different placebo response rate in this study compared to the ones that we looked at for semaglutide and for resmetirom. But again, I think the point here is the delta, the difference between a placebo and the treatment arms, which is quite impressive here in this phase 2 trial for the first outcome, which is resolution of MASH and no worsening of fibrosis. Also encouraging data for reduction of at least one fibrosis stage. As you can see on sort of the right-hand side of this diagram, for the placebo, it was 30% one stage reduction, but it was about 50% combined across the three tirzepatide arms. It was interesting that there was not much of a dose response for different doses, but it could be just a function of the size of the study because it was a phase 2 study. But overall, it was statistically significant and again, very encouraging, some of these data. Side effect profile was also quite reasonable and very consistent with previous findings in people with diabetes and obesity because this treatment is used very commonly for those indications. The most frequent side effects were again GI, gastrointestinal, were mostly mild to moderate. And I believe less than 5% of patients, they resulted in discontinuation of treatment. So it really was well tolerated. And one thing that I want to mention is that close to 90% of patients, I think it was 87%, patients who completed the trial. So it really was well tolerated. So overall, really encouraging data, really pointing out to multiple options that we have available for our patients. So we spent a lot of time talking about liver fibrosis. We need to look for liver fibrosis. We need to keep an eye on it as we give patients these treatments. We need to see whether it's improving or not improving. What do these treatments mean long term for liver fibrosis? And why does it matter? What impact does improvement in liver fibrosis have on long term outcomes?
Yeah. So I think when we started looking at the disease, at certain point, if you guys recall the 2012 guidelines as for liver biopsy to look for MASH, and that has changed over time when we started getting the data that at the MASH and F2, which we call it significant fibrosis and higher, when you start having the risk of morbidity and mortality over time. And then especially it goes up exponentially at the F3 and F4. And now reversing fibrosis started showing data that it is associated with less decompensation as you would expect and liver-related outcome. So liver fibrosis became really the bar that we're looking for. And of course, in addition to reversing steatohepatitis, which drives the engine of the fibrosis. But it's one of the things that hepatologists and gastroenterologists look for all day, that you need to drag that fibrosis down so your patient has a better outcome on the long term.
Ray, any thoughts from you on this?
I completely agree. The age-old question in hepatology is, can you treat a condition that doesn't intervene at the pathophysiology level, but just regressed fibrosis? Is that meaningful? And, based on these studies, we can't answer that question still. And I don't know if it is still a relevant question. Both agents turned off the MASH signal and improved fibrosis. So things are moving in the same direction. So no question there.
Yeah. One thing that I will mention, we don't have long-term data for these treatments just because the trials are limited in duration, but one can look at data from bariatric surgery, metabolic surgery. So those data are emerging, and you do see a very strong signal for improvement in fibrosis short term, but also that translating into improved patient outcomes long term. So I think there is a signal there. We'll have to see if that pans out with these drugs, but it looks promising. What are the recommendations do you have for these patients?
Weight loss is key. Actually, the trial in MAESTRO-NASH was done with weight loss. The drug is recommended with weight loss or weight management, so that's important. And of course, avoiding alcohol, and keeping an eye on the heart and comorbidities is one of the cores for managing this disease. So it's holistic approach, not necessarily like, although we say liver directed therapy, we have to keep an eye on other things at the same time.
And how often do you monitor patients for improvement or worsening?
I would tend to follow the guideline that we put together. So if patients who are actively being treated, I would monitor them more closely. Um, Depending on the situation, 6 monthly sounds like a reasonable interval. If the patient is not being treated, if the patient has enough signal to be concerned that there is a future risk of progressive liver disease, I think the patient needs to be seen on an annual basis. If there's no evidence of concerning fibrosis, the interval could be longer. The combination therapy is the brave new world in this.
Great. And I'm going to add to that that the pipeline is rich. There are the pan-PPR coming to raise point that there will be combinations. GLP-1s are coming. The GLP-1s are not one kind. There's the GLP-1 only, semaglutide, the duals, GIP, such as tirzepatide, GLP, glucagon. You have pemvidutide, survodutide out there, phenylbutidide, and many others. And also another very exciting class of drug are the FGF21's receptors, and there are 3 now in clinical trials, efruxifermin, bicosafermin, and efimosfermin. So it's a long list. There are multiple reviews paper that we can refer you to. And I think I'm gonna close with the last questions. Um, Maybe I will turn to Fasiha and ask her a couple of last bullet points, advice for the audience, and then Ray, and then we close.
Yeah. So thanks, Mason. I think this is all exciting. Lots of ways we can diagnose and lots of ways we can treat. It is going to get better. I tell my patients we are in a much better place today than we were 2 years ago in terms of treatment options. But the key is to find people. It's a large population, as we started off with. 30% could have MASLD. Quite a few of them probably have clinically significant fibrosis and they are undiagnosed, unaware. So these treatments, the promise cannot be fulfilled if they don't reach the population that they need to reach. So I think that one key takeaway is to really be proactive about identifying patients who are at risk and potentially can benefit from these treatments. There are great treatment options. More are in the pipeline. So whichever system you use, I think implementing that system, be it using imaging-based non-invasive testing or using a two-tier testing, but having that system in place and setting up partnerships with other colleagues because it is truly a holistic approach to patients that's needed for this population. So I would probably point that as the number one key point from my end.
Dr. Kim?
I'll echo Dr. Kanwal that liver disease mortality doubled in the past 2 decades. And the only way for us to bend the curve is to go out and diagnose patients in stages where liver fibrosis is reversible. And early diagnosis is super important. But as a specialty physician, we need to have our game plan ready when patients come through. And I hope I emphasize the need for holistic assessment of the individual. We can fix their liver fibrosis, but if they die of cardiovascular issues soon after our involvement, then it doesn't do any good to anybody, obviously. So that perspective, I think we need to emphasize appropriately.
Doctors Kim and Kenwell, I could not thank you enough. That was a fantastic discussion, and I hope we were helpful to our audience today. Thank you very much, and until next time.
Thank you.
Thank you.